We're hearing about how years ago patients used to have a whole lung removed, and then we got a bit more sophisticated and were able to remove part of the lung and do a lobectomy. But in many cancers now, we are becoming even more focused on that tumour with targeted therapy, with laser therapy, with cryotherapy, with more targeted radiation therapy that you've talked about. Do you think that we will move away from lobectomy? Removing a whole lobe of a lung is still a major operation. Do you see more of a role for targeting directly into the centre of the tumour without even removing the lobe?
I would say in the future, yes. I think there are some limitations. One of the advantages of a lobectomy is that they're able to take lymph nodes out as well and sample those. And so any in-transit lymph nodes that were not sampled initially, if there's disease in those are removed. And that leads to the improved regional control of lobectomy. I think that perhaps with the addition of improved systemic agents for high-risk early-stage lung cancer patients, perhaps we may move towards a more focused therapy. But as far as it stands right now in lung cancer, lobectomy in operative patients is the standard of care.
And you've talked already about early-stage disease versus late disease. Once a patient has a lobectomy and the lymph nodes are sampled, if those lymph nodes come back positive, does that mean to you that the patient is in a late-stage category, or do you still... How do you categorize the patients?
Well, I think traditionally anything that is less than stage 4 is considered curable. That is evolving, of course.
So define stage 4 for our patients.
Stage 4 is disease essentially outside the thorax, when the cancer has moved outside the thorax to other distant organs. And traditionally anything below stage 4 has been considered potentially curable. Of course, it's an evolving landscape, and there are some interesting data in oligometastatic patients where you can have significant long-term survivals in those cases with appropriate therapy.
Dr. Horn, we're hearing a lot in other cancers where we may give patients chemotherapy without any evidence of metastatic disease. We're giving them adjuvant, neoadjuvant therapy for bladder cancer, where the patients will be given chemotherapy before the bladder's removed, even if there's no evidence of disease outside the bladder, because that has been shown to improve survival. And we're seeing this more and more with other cancers. Do you think there's any role for patients who have localized disease of giving them some Bolton braces, immunotherapy, systemic treatment, chemotherapy to kill off microscopic cells that Dr. Sandler's team may not be able to detect? So we assume they're localized, but they may in fact have microscopic cancer cells traveling around the body that we can't see. Is there any role for systemic treatment in patients with localized disease?
So there definitely is a role for patients who've had surgery and their tumors were either larger than 4 centimeters or if they had lymph node involvement. Those patients are generally treated with 4 cycles of adjuvant chemotherapy. Right now, there's no role for immunotherapy or targeted therapy, but that's being explored in the context of clinical trials. There are also trials that have been completed that looked at neoadjuvant therapy, so chemotherapy before surgery in patients with stage 1 to stage 3 disease, also showing a small survival benefit. And there are trials that are looking at neoadjuvant immunotherapy as well as targeted therapy in patients with early stage disease as well. So one of the benefits of therapy before surgery is it gives us a better idea of the biology of the cancer. So is this a tumor that responds to chemotherapy or immunotherapy or targeted therapies? And it can also potentially make the tumor a little bit smaller, making surgery easier.
Sure.
However, if a medical oncologist is thinking about that up front, the patient needs to see the surgeon first. So the surgeon needs to be part of that discussion of, yes, if you give chemotherapy first, I do think I can operate on this patient. We should never go forward with chemotherapy and radiation therapy and say, oh, halfway through we'll have you go see a surgeon. A surgeon needs to be part of that upfront decision-making for that patient.
Now we know that these patients with lung cancer who present with a tumour in one lung, of course, have 2 lungs, and the risk factors that led to them getting lung cancer in the first place. If it's going to affect the right lung, the left lung is clearly at increased risk. Do you think in the future we may be treating high-risk patients who are already at high risk of developing lung cancer or may have even had cancer diagnosed and treated in one lung, that we may give them some preventative immunotherapy to stop them ever developing cancer in the other side? Do you think that we may move towards getting in there before a cancer diagnosis is even made?
So that's a great question. I think that everyone wants to use immunotherapy everywhere. But I think it's a cautionary tale. They're not the panacea we thought they were going to be. They only work in a subset of patients, and they have toxicities. And especially in patients where our goal is cure, for a patient who develops a severe toxicity such as pneumonitis, which is inflammation in the lung, or colitis, which can manifest as persistent diarrhea, those toxicities are pretty debilitating and can often last for months or years in patients in terms of recovery. So I think the biggest lesson we know from once you have one lung cancer, we know that there's about a 2% risk per year of developing another lung cancer. And so those patients should continue to be screened after surgery and completing their chemotherapy regularly because of that higher risk.